to welcome everybody to the topical roundtable webinar series with the Lifesaving Society Ontario branch. My name is Adrian Wong, and I'm the Lifeguard Services Chair. The Lifesaving Society Ontario is situated on the ancestral lands of Indigenous peoples, a region rich in rivers and lakes. We are grateful to pursue our drowning prevention work on this extraordinary territory. These are the sacred lands of the Anishinaabe, the Haudenosaunee, Mississaugas of the Credit, and Wendat peoples, and home to many Indigenous peoples from across Turtle Island. Welcome, everybody. I would like to introduce our speakers for today. First off, I'd like to introduce Scott Ruddle, Lifeguard Services Committee member. And also, I would like to introduce Merrick Holk, who is the Program Manager of Lifeguard Services with the Lifesaving Society Ontario.
Adrian, I'll ask this first question to you, and then Scott, obviously, you can jump in. From the National Lifeguard item description, there is a change in terminology. For those that remember, in the former National Lifeguard program, there was a big focus on immobilization, whereas now the focus in National Lifeguard has changed and shifted towards spinal motion restriction, or SMR. That also aligns in other training program areas, but for this conversation, we'll focus to National Lifeguard. So from a macro lens, and then as the session proceeds, we'll get into much more minutia detail. What's the difference between immobilization and spinal motion restriction?
Thank you. I'll go first, and then Scott, if you can kind of fill in the blanks, that'll be great. One of the key changes that the lifeguard services that we saw as we're looking at the new standards, as it relates to this terminology, is sort of like when you think of immobilization. Immobilization, the word we're all very used to. I grew up with the word immobilization. I'm slowly, even for me, taking taking a little bit of time to get out of that word into using sort of like the terminology of motion of victim spine restricted throughout. And I think the challenge with immobilization for those that grew up with this term is that immobilization can be seen as no movement at all. And I think, when you're looking at sort of like spinal injury management, the goal isn't to not move the spine at all. It's to, similar to the first aid concepts, right? Minimize movement, so that it would prevent further injury, right? So the idea of no movement at all, I think, just through time, sort of like the lifeguarding, the style, let's call it, has kind of evolved into, if you move one small muscle as you're doing the spinal boarding, whether you're in bronze med or otherwise, then it's a fail. Okay, and I think that, that's sort of like the culture that we kind of got used to. And when you look at sort of like what the industry is doing right now, as it relates to whether it's the paramedics or fire and how they manage, like clinicians, as they manage spinal injury management, is not immobilization, but it's actually using terminology like, like spinal motion restricted. Restricted is not necessarily a looser term, but it's more, in my opinion, a more realistic term. If you can restrict movement, it's enough in comparison to absolutely no movement. You better not flinch. You better not sneeze. So that's sort of like the real change is. I feel that moving forward with this whole NL update, we are transitioning into sort of like what is realistic, what is aligned with sort of like industry practices as relates to those particular fields. Scott, what are your thoughts as relates to, you're in the industry, sort of like what have you seen, as relates to sort of like changes in your industry, and does this align with sort of like what you guys do in London?
It totally, not even just in London, but in, like you said, in paramedic services across North America. I believe a study was done where they took 10 healthy people and put them on a backboard. And then after about 15, 20 minutes on the backboard, they said, anybody have back pain? And it was nearly 100% of people were saying, oh, now I'm achy in my shoulders, I'm achy in my hips from lying on a flat board, even with trying to pad voids like in the lumbar area and that. So immobilization is not what we're aiming for now. Now we're just looking to remind somebody, hey, you're injured, try and lie still. Let's keep you as comfortable as we can, but let's not go and aggravate the injury. This also falls in line with the medical position statement from the ILS, where they said that the direct mechanical injury from the traumatic impact can compress or sever the nerve tissue. This is followed by secondary injury, where if you had bleeding within the column of the vertebrae, that could put pressure on the spinal cord, or even the bones. Even bones themselves can swell, and that pressure can cause damage, can cause temporary paralysis. The fact is that that initial injury is usually what caused the problem. So the person diving into the pool, they fracture a vertebrae, they sever the cord, nick it, they start having that swelling. They then looked and said that the risk of worsening the spinal injury in the pre-hospital period is probably less than previously thought. It's important to minimize it and try and reduce the extent of that secondary injury, but caution has to be taken when moving those people around. But having somebody just lie flat on a mattress, that's what we typically do now. We use our backboard as an extrication tool, and then we remove the backboard and have them lie just on a padded mattress. If we put a collar on, we put it in on the lowest setting just to kind of remind them not to move around. But, I can do this, and guess what? I'm still going to walk. Our spine is incredibly mobile. And if a bone was fractured in there, yes, you'd want to limit it, but putting somebody in a vise and holding them there, taping them down to a board, strapping them down, all of those things are probably going to lead to agitation and people trying to fight that resistance of being strapped down, which could lead to further injury or at least more being uncomfortable. So yeah, we're not looking to immobilize. We're looking to just restrict the movement. And I'm going to keep saying this all night long. We're going back to the 3 Ps of first aid: preserve life, prevent further injury, and promote recovery. And that's what our aims and goals should be.
Okay, Scott, I actually have a follow-up question for you. So let's say if you were to coach a new paramedic, okay, you're the senior, they're giving you a new person, and then what would be sort of like the things that they would do where it would be an indicator for you, be like, ooh, that's not spinal motion restriction. Oh, that's a little too much. Gotta tone it down. Like, what would be sort of like those indicators that would be like, all right, we need to make it and bring it back to alignment of what we ought to do. So in your field, what would that look like?
So most of the time when I'm coaching a new paramedic from the college, they've received all this training through their classroom sessions.
Mm-hmm.
And what I'm really allowing them to do is work on real human beings out in the world. The most common problems or things that I end up coaching people on, one is understanding that we never want to put any upward stress on the neck. We don't want to be applying any sort of traction or anything. And people don't understand that. When somebody moves, you have to move with them to kind of maintain the position that they're in. I'm not restricting it, but I'm helping to maintain neutral alignment. The other thing that I know we don't concentrate on much as lifeguards, and we concentrate a bit more on as paramedic, is talking about the neutral alignment when you're looking from the side view. So if I turn my chair here and I was sitting, I don't know if I'm on my camera, if I have the meat on the back of my shoulders and everything, I might have to put padding under the occiput of my head as an adult to make sure I'm maintaining neutral alignment. If I have a child, it's going to be the opposite. They have such a big head and a rather large occiput, the back of their skull, that I would have to put padding underneath their shoulders to help maintain neutral alignment. And that also comes into the sideline course. If I had a football player who was wearing shoulder pads, if I go to remove the helmet to do airway procedures, I might have to put padding underneath them. So that's where more of the concentration is that way, I think.
So then would you, you know how sometimes when you look at, I guess, our aquatic terminology, right? Sometimes you might see things like victim in position of greatest comfort. Do you think that that kind of applies, you know, as it relates to sort of like this new movement of it's not immobilization, it is motion of victim spine restricted during the rollover if required and throughout? So if let's say somebody is saying, oh, I'm not comfortable, or I'd be comfortable more in this way, should that be considered as it relates to managing individuals with suspected spinals?
I would guess that you would have to a little bit, but the only caution I have is if you have a broken bone, what position is going to be comfortable for you? We will, I mean, if I broke my forearm, I would, no matter how well it's splinted or padded or whether I hold it against my chest or anything, the bone is still going to hurt. And after a cervical spinal injury, or if I jump in feet first in shallow water and I do a compression injury on my lower back or my thoracic vertebrae, there's going to be like no position of comfort. And maybe that's where talking to the patient, coaching their breathing, encouraging them to try and relax. You may be able to adjust a little bit, but I mean, you're going to be at some point where you can't get to zero. I mean, that's going to be done with, you know, medication and analgesia at the hospital, I would imagine.
So for those that recognize the former National Lifeguard program, there was the emphasis of immobilization of head and neck, whereas the current verbiage, as I have it in front of me, says motion of victim spine restricted during rollover if it's required and throughout. Oftentimes in aquatics, when we're training, we typically train towards the worst case scenario, being face down, non-breathing immediately after, right? Typically they may walk, they may be conscious, they may be able to get themselves out of water and so forth. But if the person is in the water, perhaps Scott, I'll leave this to you first, and then Adrian, if you want to jump in, what are some strategies or some techniques that will help achieve the must-sees of spinal motion restriction that we can utilize for both conscious and unconscious victims?
So the techniques that we already use that we learned through the bronze courses, you know, the log roll, Canadian, inverse Canadian, vice grip, modified. So all of those things meet the must-sees of restriction. As soon as you roll somebody over, technically they're no longer immobile. You've moved the patient. Bringing them over to the side. Some of the other things I see, people walking in circles and circles and circles and circles. It's like, you can come to a standstill while you wait for your partner to bring a backboard. If their feet sink, you may have to adjust the patient a little bit to maintain that neutral alignment. But I don't have to be doing laps of the pool with this poor patient, you know, while I'm waiting for a backboard to show up. After the removal, that's when I think it comes a little more into play. If I've removed them and we're readjusting straps, or maybe the patient then says, hey, can we loosen this strap a little bit for my comfort? That's fine. If they say, can I get off this backboard? I would be reluctant to do that because until the paramedics arrive, you're going to have to lift them back off the floor. And some sort of a lifting device is going to have to go underneath them. They might not need tape across their forehead, maybe just head packs beside them so they're not, you know, rattling their head around would be sufficient to meet that restriction as opposed to the immobilization. Using the NL USB keys, I was able to look at the lesson plan overview for the spinal injured patient. One of the key parts that I saw down here in the introduction was to have a discussion with your candidates of the likelihood of the injury taking place in specific parts of the pool. shallow end versus deep end off a diving board or some sort of a structure. And I really hope that that's something people employ a little bit more, because as many NL instructors can probably relate to, you'll be doing situations, you'll set up a sit, somebody is standing in the middle of a wading pool, has a syncopal episode, maybe they've had a cardiac event, they go down, and then our candidates want to run out to the middle of the pool because it's shallow and roll them over and get them on a spine board. And it's like, how did they have a spinal injury in the middle of a pool? You know, like they didn't dive in. You were, hopefully you were scanning, you saw them standing, you look back, you saw them in the water face down. The likelihood of a spinal injury is not feasible really in that scenario. And I think that's where we do a credit to our candidates by saying, hey, look at the mechanism of injury. What could have happened? Did they take, you know, did they come off of a diving board and hit their head on the springboard? That's a spinal probably. But if they're out in the middle of the pool and they roll off of a pool noodle or a floaty lap and you didn't witness it, it doesn't mean that they got a spinal. They're out in the middle of the water there.
The victim is a unconscious, non-breathing, face-down victim. So I'm sure everyone can visualize someone in a prone position, face down. Scott, I'll ask this question to you first. If the victim is not breathing, face down, do you roll them carefully, jaw thrust, and begin CPR, or just roll them over quickly and start CPR?
Personally, like I said, I'm going to go back to the 3 Ps of trying to reduce any further injury. Rolling carefully, if I'm a single rescuer, it isn't going to be as well as having multiple rescuers, but I can still, you know, grab them by the shoulders, kind of cradle their neck in my hand and roll them over carefully. I would prefer to do a jaw thrust without head tilt initially, to try and open their airway. But if that wasn't sufficient, then a jaw thrust with head tilt is what we would be going on to next.
So, Scott, you said that you would want to try to do an open airway without tilting the head first. If the head is off to the side, so this is another question that just came in the chat box. If the head is to the side, are you able to move the head to that neutral alignment to be able to get an airway, or is that not wanted?
So neutral alignment is what we always aim for. And guess what? We weren't born this way. We were born this way. That's what gets things back into neutral alignment. The only direction that we have with regards to moving people's necks is when they are conscious, we try to readjust to a midline position. And if they claim to have pain or it hurts, then we try and pack in position found with towels or padding. With the unconscious person, they're not complaining. That's one of the best thing about unconscious people. They don't complain too much. But then that's where you want to get into neutral alignment, because that's the way our equipment works. You know, our OPAs, our bag valve mask, they're meant to be used when somebody is lying in a supine position.
Awesome, Scott. Adrian, I'll ask the next question to you related to, I'm going to add kind of 2 questions into one. We'll start off with land spinals, and then I'll kind of move into more of the curriculum stuff. So do we have to, when you're teaching National Lifeguard, because everyone here is a National Lifeguard instructor at minimum, do we have to teach land spinals? And then the second part of the question is, when should you start teaching spinal injury management when you're looking at the entirety of the course?
Okay, thank you. So the first piece, do we have to teach land spinals as NL instructors? We don't have to. If you actually look at the appendix talks about sort of like any of the first aid items that you could use for scenarios. It is listed in here as that they kind of need to know this, right? So land spinals, for the most part, really should be taught prior to the course and should be a prerequisite from the standard first aid aspect of it. Now, given that, just because they have the prerequisite as an NL instructor, sometimes you might need to spend a little bit of touch-up work on it. So maybe touch-up work as relates to land spinals, but not necessarily teach it completely new as a whole. I think looking at the management of spinal injured victims, in terms of the management of it, in terms of the must-sees, I think so as long as you're comfortable with sort of like their prerequisite skills, there should be no reason why they can't manage and deal with a land spinal and still meet the must-sees and meet the intent of the must-sees in managing the victim. So not necessarily teaching it. The second question that you mentioned was when to teach spinals. Is that correct?
Yeah, so when you're looking at the entirety of the 40 plus hour National Lifeguard course, when do you start introducing it? When do you start introducing spinal injury management?
For the most part, the Lifeguard Services Committee worked really hard on the Teaching National Lifeguard USB. We kind of looked at, I guess, organizing a course outline similar to how it is with swim and life-saving instructor, where you have sort of like, the 0 hour to the 40th hour and then everything else in between. If you, for the NL instructors that are out there, if you haven't seen the Teaching National Lifeguard USB, definitely encourage you to take a look at it. Hopefully, we provided a lot of resources that are useful. Specifically with when to teach it, not my recommendation, but one of the many ways to do it that we put into the USB was to kind of teach it closer to the 40th percentile of the course, not halfway into the course, a little bit beforehand. There's no real, it's not like backed by research why we need to teach it at the 40th percentile mark, but really it was just more just flow of ideas. What we did was that we kind of wanted to teach it a little bit early. And then also break it up a little bit, because management of spinal injured victims, it is a long topic. You're not going to spend 5 hours teaching management of spinal injured victims in one sitting. The benefit really is to break it up into smaller chunks and then use a progression approach, logical progression approach, to build on their spinal injury knowledge and experience. So I think we started off with, I think there was like 3 sessions of spinal injury management, kind of broken up into chunks. But the first chunk really, I think, starts at the 40th percentile time block, and then it slowly builds into, all right, so, well, what are some complications? All right, how do you apply specialized techniques depending on the pool that you're at? And then also, I think, building from, hey, what do you do if they are breathing? And then what do you do now if they're not breathing? And then getting them to be able to kind of switch on and off so that they know that it is not, I'm just going to use one way to deal with spinal injured victims. If they're breathing, I got to go one way. If they're non-breathing, I need to pivot and I need to do something else. So there were multiple sections that we've kind of put in, I think at least 3 sessions of spinals in smaller chunks, but definitely hopefully getting them to see the full scope of the item.
If I'll just throw in there, remember that each of us has a different pool with a different timeline. It's going to depend on pool space. It's going to depend on when equipment is available. So it can occur in many different locations because it's a newer skill in that they've already had the rollovers from bronze, but now we're actually showing them strapping and putting on a board and extricating and that form of teamwork. Maybe a little more practice for the skill is warranted. I've taught March break courses where sometimes we actually do skills during public swims, and I've utilized that. I've gone over to, the wading pool and ask for, a 4-year-old volunteer. It's like, hi, do you want to come and lie on my board for me? And use that as a teaching moment. Just say, hi, here's your V-block spine board and the straps are here and here. Guess what? They don't fit on this 4-year-old child. And show people how their equipment could be utilized and adapted for many, many different victim types. So start it early. not too early. Don't over. I mean, we're trying to break them from being a lifesaver into a lifeguard, but then start getting those lifeguard skills. Give them chances to use, practice, play.
On the theme of strapping and spinal board use as an extraction tool, the next question is, do you have to use the straps for the spinal board? If and when would you not use the straps? And then if we can just kind of get into the conversation of, this new item requires non-breathing victim care for suspected spinal injuries. What does that look like in terms of removing the person from the water to be able to start CPR? So Scott, I'll pass it off to you first. Spinal boards, do we have to use the straps? Do we not have to use the straps? And how do we remove somebody that is a non-breathing victim from the water if they have a suspected spinal injury?
So when the person is conscious and they're able to communicate, their airway, breathing, circulation is all intact, utilize your straps. Straps are there to stop people from slipping off and causing further injury. So utilize the straps. Remember to teach that straps should go over bony parts of your patient, meaning I frequently catch, once again, just because of a size on a board, somebody says, oh, well, this is the waist strap, I have to put it on, and it's right over their mid-abdomen. That's really doing not that much. If they could crisscross it over top of the pelvis, if they could adjust it some way, shape, or form, you want to be on top of bone, because that's what secures you. Take a big breath in or a little breath out so that you still have rib movement for free breathing. When time is of the essence, so now you've had somebody who's been face down for a while, and I think we all have to put it in perspective too. Like, how long was that person face down before you caught it? It doesn't mean that they can't go non-breathing right away, but people can hold their breath for a couple of seconds. I have used a backboard with just one strap underneath their armpits and shoehorned them out. I have, with a partner who is trained in the procedure as well, we have just both held hold of a patient's wrists, and with no straps, we have been able to shoehorn somebody up onto the deck as well. But you do run the risk that they could slip and slide off. If I'm in shallow water and able to stand, and I have once again, a partner who's jumped in and is helping me support my patient, you can do, I don't know if there's a name for it left, but kind of that fork lift, lift and set them on the deck. That works as well. I know, were we planning on showing the video sometime tonight, Merrick? The spinal video?
Adrian, I guess it depends on time. What I can do is post the YouTube link in the chat box, and then people can copy and paste it into their browser to watch. But before I do that, I'll have to give a disclaimer regarding it.
And I understand. So maybe I'll just reserve my comment on something that's in the video, but I'll wait till the disclaimer and we talk a little bit further on that. So it depends how much speed you need. It depends who you've practiced with. Straps, like seat belts, hold you in the position you're supposed to be. So how many you need is the question of how fast you need the person out of the water, I guess.
And Adrian, before you respond, if you'd like to, you mentioned, Scott, a term called shoehorn. I had some questions in the chat box, meaning what does that mean? Can you just briefly explain what you mean by shoehorn?
So my patients in the water, I just bring the board in along the wall and just kind of pull them up onto the deck. I guess sort of like a reverse shoehorn. A shoehorn puts the foot in, we're pulling the patient out. So using your levers, which levers make it easier for some of our smaller lifeguards who might be pulling out a larger patient. We use backboards as an extrication device for people with hip injuries or leg injuries. We use backboards as an extrication device for when you have the 300-pound aquatic facility guest and you want to get them out of the water. And you wouldn't be able to do the traditional, under the arms chicken wing and somebody trying to, slap on the deck 3 times and start hauling and everything. So it's an extrication device. It removes them from one location to another. It helps to splint bone injuries as well, like any good splint does. It restricts motion from the joint above and below the point of injury, but it's an extrication tool as well.
On the continuing topic of strapping, maybe Adrian, you can take this one first. Is there a standard for strapping? Do you have to put the straps horizontally? Do they have to go cross, or does it even matter?
My general practice is kind of going with sort of like the manufacturer's guideline, because I have used various spine boards before. So I think I've used sort of like the V blocks, which a lot of people have. It's the gray ones, versus using like Furno boards, where it's a little bit, there's no tracks. It's kind of yellow and it's very floaty, and it's a lot of sort of like kind of hooks and whatnot. So for the most part, I haven't really like I haven't really seen anything that is like, oh, you must strap like this or else. I think following manufacturer's guidelines as relates to the boards, I think would be helpful, number one. Number two, for the most part, I use the general concept of strapping. If I'm strapping somebody down, it's kind of like kind of put some logic behind it, right? I usually say to my NL candidates, like, what are the heaviest parts like of your body? And it's not your head. It's sort of like probably your chest and your hips cover the majority of your weight. So if you are immobilizing, or not immobilizing, oops, I'm sorry, the spinal motion restriction. I told you it's going to take me a long time too, but spinal motion restriction of the individual, right? Trying to above and below the injury, right? Similar to any type of splint, as kind of what Scott was saying, right? Above and below the injury will at least hold sort of like that particular area that is in question in place. So, I think it depends on the board too, right? If let's say the board, certain Velcros don't work well, and the other one that is underutilized works really well, and you can somehow make it work, maybe it's not even Velcro. Like maybe it is, like finding ways of tightening it. And that might be a cross strap that is atypical of that usage of board. So I think there just needs to be a little bit of logic behind sort of like how you utilize the straps. But general rule, I would say is, supports the heaviest parts of the body. And if there's manufacturer's guidelines in terms of how to utilize that board, then I would go with that.
Manufacturer's guidelines all the way. So manufacturer's guidelines, because the first thing that they're going to do, if heaven forbid somebody ends up in a court case, the first thing that any lawyer is going to do is, let me see the manufacturer's paperwork. Did you utilize this equipment as it was meant to be utilized? And that would be their look to see if you're doing something that is contrary to how the equipment is being used. That's going to be their in.
The phrase that I usually use when National Lifeguard candidates ask that type of question is, if they exist and it was meant to have it, then it should be used. Unless obviously you have a reason not to use them. For the example, that the victim is not breathing, and then it becomes life over limb. But if it has it and it's intended to be used, then it should be used. One common discussion that I usually have regarding horizontal straps and cross straps is that there's no standard, as Adrian was alluding to, but there's that misconception that practice at a specific facility becomes the standard, and then that information gets transcended when that lifeguard trainer or instructor examiner goes to other courses and tries to preach what their own facility practices as the standard. So there is no standard related to horizontal or cross straps, but there could be rationale for when you use certain ones over others. For example, if the victim, in extracting the victim's body position happens to be a little bit lower, doing horizontal straps might not work because you might be putting the horizontal strap across the airway, right? So in that context, it might make more sense to do cross straps, right? So victim location on the board might matter in terms of which process you end up using. However, if you use horizontal or cross, there's not a standard either way, but there might be logic for when you use one over the other. In the chat box, sorry, Scott, go ahead.
The only one that I try to encourage being straight across is the one that's up high across the chest, because as you start to slant and pull the person up onto the deck, they want to slide down the board. And if you have it straight across, then they tend to come to rest on in their armpits and stop, further movement towards the foot. Patient anatomy sometimes is another factor. If I have a patient who has a large pelvis and a small waist, then crisscrossing over the hips and kind of doing an X across that pelvis seems to lock it in a little bit better than just doing a straight strap across. But that's, but it's still following, as we keep saying, the manufacturer's guideline.
There's probably one significant difference or thing that you might have noticed with the Recert items, and there's one item that is no longer part of the Recert item. So Adrian, why do we no longer assess spinal injury management in a Recert?
Looking at sort of like, so if for those that are here that remember the last, the last update, 2012, there was a similar setup that I'm going to use that as an example first. So with the 2012 update, there were 6 physical items and only 3 of them are in research. Okay, so for example, we have something like underwater swim for 15 meter for the distance. Okay, that were you teach it for the original course, but it's not a research item. So in this case, for this round, it's with management of spinal injured victims. So one of the my thought process as relates to this change that was done was that it's something that the lifeguards needed to know. But as relates to the lifeguard maintaining their skills to continuously do their job, it is not considered to be mandatory. It's important for them to have that baseline, but it's not something that needs to be checked or rechecked, unlike the endurance swim or unlike the sprint. Or the brick. Okay, so that's sort of like my general thought as relates to the managed spinal injured victim. To me, management of spinal injured victim, I kind of see it somewhat similar to almost like a facility search of missing persons. Okay, when you think of it, there are commonalities between the two. Facility search of missing persons, it's a lifeguard procedure. It's in Chapter 4, similar to management of spinal injured victims. It is very step-by-step. It is also very facility-specific as well. So when you think about going to an NL Recert, let's say you need to travel to go to this NL Recert outside of your municipality or organization, because that's the only one that fits your schedule, you need it before work, you're going to go to a facility where it's going to be atypical to sort of like where you work. Yet you're practicing a very facility-specific item. So I think that's one piece to consider, is that really, as it relates to the maintenance of the certification, I like how they've organized this now, where there is less of an emphasis on the maintenance of the management of spinal injured victim in a research where it needs to be generic and that needs to meet sort of like the industry standard. Yet they put a lot more emphasis and attention on scanning. If you look at the research, they got rid of management of spinal injured victims in the actual research piece, but now they're scanning and observation. Scanning and observation is no longer just a note as a one must-see item within the lifeguard situations. You could evaluate scanning and observation as a standalone piece. In some of the other options, positioning is also a thing as well, in addition to scanning. When you think about how to build better lifeguards to be able to do their job, scanning, observation, positioning will give you more bang for your buck than focusing on something like management of spinal injured victim, where I think Scott and I were having conversation about the likelihood, like in all 3 of our experiences, how often have we dealt with an actual spinal injured victim in the water? versus, in our lifeguarding career, how often have we applied scanning and positioning and used that to prevent accidents from happening? So really, the lifeguard research is all about, they already have the knowledge and base, but we need to tweak sort of like their, make sure that they can still do the basic fundamental skills that makes them a lifeguard and that will make them better lifeguards for the next 2 years before they recertify again. So I think that's one piece to consider. The other hat that I wear is that I'm a recreationist by trade. I work and I manage pools as well within the York Region area. So for me, putting on that kind of hat on, I really do see management of spinal injured victim really is a facility specific item. If, let's say, somebody comes to me from another municipality, another organization, they took their national lifeguard somewhere else, I don't really care where they took their national lifeguard pool. I need to streamline them. It is the facility's responsibility, the affiliate, the organization's responsibility to streamline them to make sure that they can deal with spinal injured victims in my pool, with my special features, with my multi-pool facility, zero depth spinals, spinals where, let's say it's an Olympic sized pool. Let's say I don't have one, but let's say it's an Olympic sized pool and it's deep versus deep. It's my responsibility to teach them as the affiliate or the organization how to manage that, not the NL course or the NL research. So I think there needs to be, in the aquatic industry, there needs to be a change in mindset in terms of whose responsibility is to build better lifeguards. It is the NL examiner's responsibility to build better lifeguards in the techniques. It is the facility's responsibility to build better lifeguards so they can do their job at their facility. So I think that mindset needs to change in the aquatic industry for us all to move forward. I think often as aquatic recreationists, we kind of get into a bit of a plug and play mode. It's, oh, you got your recertification, all right, done, and I don't blink an eye, I don't bat an eye, or think twice about what is your skill set. So I think there just needs to be a change in mindset. But that will be my comment as it relates to why it's no longer in a research. I think that there's definitely value, but then I see it from what does a lifeguard need? And then the second piece is whose responsibility really is it to train people on facility-specific items like management of spinal injured victims once they become lifeguards.
From the Lifesaving Society certification perspective, Lifesaving Society is a certifier of lifeguards, which means at the conclusion of the National Lifeguard course, the evaluator, or in this case, the National Lifeguard Examiner, certifies that the individual was able to meet the must-sees of the course at the time of certification. The National Lifeguard Program is developed under 4 competency areas, which includes knowledge, skill, fitness, and judgment. So at the time of certification of their original course, that evaluator, the examiner, certifies that that lifeguard has the knowledge, the skill, the fitness, and then the judgment necessary to be certified as a lifeguard. And then further to Adrian's point is that at the pools, there's so many different techniques that may be learned for big pools, small pools, cold pools, warm pools, long pools, shallow pools, etc. And that's where that specificity is. So what we want to focus on is the prevention aspect of preventing drownings from happening, focusing on the element of scanning and observation, and keeping situations realistic to what the lifeguards will actually experience in real life. Not to say that they're not going to experience suspected spinal injuries, because they are, but we want to focus on the things that are most common. Appendix A in the National Lifeguard Award Guide has had some updates since the old National Lifeguard Award Guide. And in the updated Appendix A, on page 91, sorry, not page 91, page 90, it adds suspected spinal injuries on land. So when you're doing situations, so item 12A or 12B, one of the possible scenarios that you can utilize are land spinals, should you wish to use that. So you do have that ability and that empowerment as the examiner to include that into your exam if you wish to use that. I think, Adrian, you did mention that we had, Scott, you and me, we did have a quick conversation before everybody joined regarding our own expenses related to the number of suspected spinal injuries that we've had to deal with in an aquatic setting. Scott, what was your number?
I've had one aquatic spinal, and I've had two land spinals, and one that I was actually just a witness to. So
I've had 3 in total, 2 aquatic and 1 land. And then Adrian?
0 and 0. I'm still waiting. So
And keep waiting. Hopefully that never has to happen. I don't know what the number of hours that we collectively have spent lifeguarding or training lifeguards in a management capacity or in a supervisor capacity or in a trainer capacity. But for the sheer number of times where we've actually had to practice that skill to the total number of hours that we've actually been practicing as lifeguards, obviously the ratio is very, very low in terms of the occurrence rate of suspected spinal injuries, which is a good thing. So that just shows again that we sometimes overtrain for spinals, and we don't need to overtrain. We've learned the skills, we've understand the practices. Facilities should incorporate it into an annual staff training plan, but it doesn't need to be an item on every single quarterly or monthly in service. You don't need to go that far, right? You should do it on an annual basis so that everyone within your facility and your pool knows what the practice is and the nuances is for your facility, but also track incidence rates of what happens at your facility and train according to the things that are actually happening.
I think we had said just before we started, Merrick, that yes, it's not something that you need to overtrain on. I mean, just like CPR, we do annual retraining. It's a reasonably simple skill, so the hands-on muscle memory probably doesn't have to be there. The one thing that I like to bring up, though, is that if I'm in this uniform and I show up on the pool deck, I'm not jumping into the water to put somebody on a spine board. I expect the lifeguard to know how to deal with the aquatic emergency. The lifeguard should know how to get them out of the water and onto the pool deck. And that's where it's that balance. Yes, we don't need to overtrain for something that doesn't occur that often, but we have to be good at the skill that we will be required to as lifeguards to perform when we have to do it.
Scott, you're a paramedic. This question's for you. Will the paramedics take the spine board that was just used during a rescue to the hospital?
That's something you can find out from the ambulance service that will be responding to your facility. With the change to spinal motion restriction, many times, once again, the backboard is an extrication device. Once I lift that person onto the stretcher, I'm going to get them off of the backboard and actually raise the head of the ambulance cot a little bit to make them comfortable. So before the days of, I got to find out which hospital you're going to send my supervisor there to go and pick up my board, it might not occur that often anymore.
So for walking spinals, do we keep them standing? Do we want them to sit? Do we lay them down on the ground, assuming that the person is conscious?
So a conscious person, I would probably get them to sit, only because standing in a still, not immobilized position for a period of time until emergency services show up may be fatiguing to a patient who's already in distress. So assisting them to sit down. If they were starting to have a decrease in level of consciousness, they were getting woozy or dizzy or something that you thought, sitting isn't the best, then laying them down on the ground would be what I would do. But I wouldn't keep somebody standing the whole time. There's numerous different techniques to do. Some people have incorporated the bringing the board behind somebody while they're standing, and then using a team of people to help lower the board down to a position on the ground. That's an option. But position of comfort, and then just kind of balancing them. I don't necessarily have to do the vice on them. I can just kind of support them around their neck and just have somebody else kind of underneath their armpits and help have them sit down in a chair as well. Many different ways to meet the must-sees.
Okay, thank you. First of all, I want to thank everybody for attending this roundtable topical webinar session. To be honest, this is actually the first time that we as Lifeguard Services Committee have run something like this. And hopefully this has been helpful to everybody, and it gives individuals an opportunity to kind of hear from different subject matter experts as it relates to the topic. Definitely, if there are other topics that you're interested in hearing more about, please don't hesitate to reach out to Merrick or send an email to training@lifeguarding.com. We'd love to see how we can better meet your needs as you're the frontline people teaching the courses or affiliates that's building more lifeguards out there. So, and I also wanted to take this opportunity to thank Scott and thank Merrick for your time and insight in the matter. It's great chatting with you guys on a Tuesday night. So other than that, wanted to thank everybody. Hope you all have a wonderful night.